Good morning, everyone, and welcome to today's webinar, PCOS, Nutrition, and Fertility. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance today will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. Additionally, we encourage you to submit questions to Hillary Wright using the questions section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them at the end during the question and answer session at the end of today's presentation. Now, without further ado, I would like to introduce today's speaker. Hillary Wright is a registered dietitian with over 30 years of experience counseling clients on diet and lifestyle changes. She holds a bachelor's degree in human nutrition from the University of Massachusetts at Amherst and a Master of Education from Boston University. Hillary specializes in nutrition and women's health issues and is the author of The PCOS Diet Plan, A Natural Approach to Health for Women with Polycystic Ovarian Syndrome, The Prediabetes Plan, How to Reserve Prediabetes Through Healthy Eating and Exercise, and the co-author of The Menopause Diet Plan, A Natural Guide to Managing Hormones, Health, and Happiness. In addition, Hillary holds a part-time position as a nutritionist for the Dana-Farber Cancer Institute in Boston, Massachusetts, counseling patients during and after cancer treatment. Previously, Hillary spent 12 years as a nutritionist for Harvard Vanguard in Kenmore and Cambridge, practicing caring for adults and children of all ages. For the past 15 years, Hillary has been the Director of Nutrition of the Domer Center for Mind-Body Health, which is connected to Boston IVF's Waltham Center. Okay, let's get started. I'm going to pass it over to you, Hillary.
Thanks very much, Alyssa. I should say I actually started seeing women with polycystic ovary syndrome while working with the fertility group at the Kenmore practice of Boston IVF. And I got involved with them because we worked in the same large group medical practice, but I also sought clinical care from them when I was diagnosed with secondary infertility. So this kind of pretty painful thing in my life turned into this really kind of rewarding professional career helping women manage their fertility, including polycystic ovary syndrome. So this is a beast of a condition to try to tackle in a short period of time. So I'm going to try to just move through the material as quickly as I can. And the idea came to me as I was pulling this together to kind of survey my social media people. So I have about 37,000 social media followers around my at PCOS diet or PCOS diet on Facebook. And so I just put out a feeler to them and I said, I'm doing this presentation and I would like you to tell me what you would like your clinical providers to know about you. And so I decided to pick, I got about 50 responses and decided to pick ones that in my experience, are really common. And I just wanted to run through them quickly just as a way to kind of set the tone of the conversation of what it is that we're all trying to do to assist these women. So some of their comments were, it's not just about fertility, it's about quality of life. For me, the doctor stopped acknowledging the problem when I had my babies. The fact that we want our PCOS treated even if we aren't trying to conceive. And I also get that question from people sometimes saying, do you see women with PCOS if they're not trying to conceive? And the answer is, of course, yes. Lean PCOS needs nutrition counseling too, not just a prescription for metformin and birth control pills. Since losing weight can alleviate symptoms of PCOS, it would be nice to have these tools. Which would be people like myself, registered dietitians. Also, not to tell women that PCOS means there's no chance to have a child. I've actually heard that a few times, and I think it's a rare statement, but I can't think of anything more devastating to say to a young woman. I also want the option of traditional and natural approaches when treatment is presented. I'm 49, and my RE practice is done with me since I'm going through menopause. So I think that, and this is fresh to me right now, having just co-authored a book on menopause, that PCOS is a genetic condition with insulin resistance as an underlier, and it doesn't go away just because somebody's in menopause. I'd like to be looked at as more than just an overweight body. I hear this a lot, and I'm very aware of this. It requires an extraordinary amount of sensitivity to deal with this population. Particularly myself, like many of you may see them when they're in the kind of the throes of trying to conceive and the stress level is to the moon. I'm overweight because of PCOS, not because I don't eat right or exercise. So to that point, we're going to talk about the weight management piece. But there are many women who are obese and eat very healthfully and exercise, and the kind of the anabolic state that PCOS represents for many women does make it more difficult, can make it easier to gain weight, make it more difficult to lose. And then truly listen. Many times I feel doctors aren't hearing the full story and they've already categorized me based off my chart. So I think more than anything, these women want to be heard and acknowledge that their challenges are really complicated even beyond the fertility piece. So in terms of the role of the nutritionist, a lot of what we do is we clarify the role of diet and lifestyle management in managing insulin resistance. So that's a lot of what I read about in my book, because we know that insulin resistance is significantly what's going on behind the curtain with these women, and managing that not only can help to optimize their fertility, but lower their risk of lots of chronic diseases. Clearly, we do a lot of weight loss counseling and support, though, again, a woman can eat healthfully and be physically fit and be healthier even if she hasn't lost any weight. Again, presents a conundrum if her insurance, for example, won't pay for assisted reproduction unless her weight gets to a certain level. So, again, there's a lot involved there. Management of diabetes and cardiovascular risk factors, including gestational diabetes, and then diet and overall counseling support around overall health and fertility. So I'm not exactly clear on everybody who's attending this, so I'm going to go through this quickly. I assume most people are aware. It's the most common disorder of women of reproductive age, though it does continue on beyond those years. Estimates are anywhere from 8 to 20%. And so they're kind of all over the place, I think, as we continue to try to nail down the diagnosis. I think syndromes are confusing, and undoubtedly there's more variance than we can probably appreciate, and hopefully we'll learn more about. We all know it's the primary cause of anovulatory infertility, hyperandrogenism, and ovulatory dysfunction. The hallmarks of PCOS, upwards of 70% are insulin resistant, and about 10% have type 2 diabetes. I'm guessing it's possible that diabetes number is actually underestimated, particularly based on what I see in my clinical practice. And it's also important to appreciate that insulin resistance occurs irrespective of weight. So lean women with PCOS are also at risk of insulin resistance. It just doesn't happen to be as severe as if a woman is obese as well. So I just want to talk about insulin for a second because it's such a big player in this condition. And I like to think of insulin at its core, it's an anti-starvation hormone. And so because insulin evolved to help human beings survive droughts and famines, it's considered a genetic mismatch when interfacing with this modern environment that we're all living in. So, a tendency towards insulin resistance is so common because we evolved, we're the descendants of the fittest, but that same sort of reduced, kind of metabolically conservative physiology can backfire and lead to a lot of health problems, including making it easier to gain weight and harder to lose it. Insulin is considered the main anabolic hormone in the body, and as a growth hormone, we're actually concerned about it tying in with cancer risk as well. It regulates the metabolism of carbohydrates, proteins, and fats, but its primary function is to help assist with the transport of glucose out of the blood into liver, fat, and muscle cells. But the bottom line is insulin's job is to store fuel for our cells to use, initially as glucose, but insulin likes to store leftover fuel for a rainy day because it's an anti-starvation hormone. So even though its primary function is to clear glucose out of the blood in the hours after we eat, insulin likes to store extra glucose as leftovers, which benefited our ancestors. It will try to, jam some of that glucose into glycogen stores, but insulin also triggers conversion of glucose into triglycerides and stored as visceral fat, which we know in a cyclical manner aggravates the insulin resistance. So as long as someone has higher circulating levels of insulin in the body, they will be in calorie storing mode. So, and I know that insulin levels are more complicated to interpret, but the general consensus is anything that we can do to help lower circulating insulin levels will benefit these women. Everybody here is, as I'm sure, familiar with the criteria and the need to rule out Cushing syndrome, thyroid disorders, congenital adrenal hyperplasia, and hyperprolactinemia. Symptoms, the more obvious ones are the menstrual irregularities and the infertility and hirsutism. Acne, it can be pretty severe. I think we've all seen it. I've seen many, many, many instances of women with PCOS who in their history described to me that when they were younger, they felt like they worked harder than everybody else to try to control their weight. and then some period of life occurs that causes some amount of weight gain that seems to fuel additional weight gain in these women. And so the weight issue is complex and is something that really needs some digging, and people like registered dietitians have more time to do that. So when it comes to figuring out what percentage of women with PCOS are overweight or obese, this is also a difficult thing to nail down. Estimates between 50 and 80% or more of women, but I have read studies that have looked at, when they've done surveys of women, screening for PCOS in the context of like pre-employment physicals, for example, they unearth a lot of women who are not overweight who have PCOS or who classify. So I think what makes it confusing is that if you have PCOS and you gain weight, you're going to be more symptomatic, you're going to more likely end up in a doctor's office and maybe more likely to end up in a research study. Clearly there's a lean variant and one that's more prone to excess weight, but I think there are a lot of people in between. And we also know that the more overweight a woman is, the more significant the insulin resistance is, and the higher the risk of diabetes, because of, visceral adiposity is pro-inflammatory. Obese women with PCOS also have lower SHGB levels, so more symptoms related to their hyperandrogenism. Weight loss is the primary goal of intervention, which the approach that I take, that I found the most resonating with these women over the past 21 years that I've been counseling them, is let's just talk about managing your insulin resistance. And it allows us to kind of work around a lot of the baggage that many of these women have with weight management. Because if they start to manage the insulin resistance, a lot of their clinical parameters will improve, but they also physically and emotionally start to feel better. I'm all about trying to do an end run around the emotional baggage related to numerous weight loss failures. So the same things that we would do to manage insulin resistance, may result in weight loss in many of these women while avoiding some of the pitfalls. But I always go out of my way, and I often will do the math with a calculator. As little as 5 to 7% weight loss may be enough to improve regulatory function and reduce some of the symptoms, even if these women now still weigh a lot more than they would like to. We know that central obesity is a pro-inflammatory state, and that will increase your risk of cardiovascular complications and diabetes risk. Pooled analysis of 46 studies suggests 30% prevalence of metabolic syndrome in women with PCOS. I actually think that sounds low based on what I see. I sometimes see these women having lipid profiles that look like men, and that they'll have a low HDL cholesterol for a young woman. Sometimes the rest of their lipid profile looks okay, but they have elevated triglycerides. Very scarily to me is that PCOS is associated with decreased fibrinolysis and increased C-reactive protein levels, contributing additionally to their cardiovascular risk. Risk of diabetes in women with PCOS is considered fourfold of women without, and about 40% of PCOS-related healthcare spending involves treatment and management of type 2 diabetes. For this reason, the Androgen Excess Society suggests an oral glucose tolerance test every other year in women with PCOS, possibly annually in women that have prediabetes already. And they also probably should be screened for gestational diabetes earlier, because pregnancy makes women insulin resistant. If they enter a pregnancy already insulin resistant, they obviously have a higher risk, and letting them know that early on, I found to be very helpful in terms of their interest in, when they do conceive, trying to be very mindful about remaining active and controlling their weight gain. This is a really interesting study where they were looking for glucose intolerance in women with PCOS using an oral glucose tolerance test, an A1C, and a fasting glucose. And this was 671 women. They gave them a 75 gram 2-hour oral glucose tolerance test. And the median BMI, I think this study was done in Europe, I'm pretty sure. Median BMI was 24.2. My average patient's BMI is way above that. 56% of these women were overweight or obese, and they used the Rotterdam criteria to define them. And what was interesting is that any of these means were good indicators of diagnosing someone with type 2 diabetes, but there were differences based on trying to tease out prediabetes. So in the oral glucose tolerance group, prediabetes was diagnosed in 12.8% of the women and diabetes in 1.5%. Using an elevated A1C, the numbers went down to 3.2% for all women with PCOS being diagnosed with prediabetes. And an elevated fasting glucose, it was 5.2%. So I understand that oral glucose tolerance tests are more labor intensive and more difficult to institute, but the point is we may be seeing normal A1Cs and fasting glucoses in women that would probably flunk an oral glucose tolerance test, or may. And I see prediabetes all the time in my PCOS patients and young women with many more years to deal with the consequences of that. Also very intimidating are the elevated risks of non-alcoholic fatty liver disease, which is taking off in the population in general. Now considered the most common cause of liver disease in the Western world, not related to alcohol. And my understanding is it's rapidly coming up behind alcohol as a #1 reason for liver transplant. Estimated to affect 25% of US adults. In this study on women with PCOS, a third of them, again, with a mean BMI of 29.5, I regularly see women with BMIs well into the 30s and the 40s. These are 24-year-olds with non-alcoholic fatty liver disease. And again, it's a consequence of the insulin resistance and all that it entails. So obviously we need to monitor their liver function test. And fortunately, again, very reasonable weight loss, 7 to 10% weight loss may make a difference in their non-alcoholic fatty liver disease. This is really emerging. We're all really interested in the microbiome. Some research suggests that the microbiome of women with PCOS may be altered. This is the more we understand or learn about the microbiome, from my perspective, the more we realize we know nothing. That microbiome is very unique to the individual, and it can be hard to tease out different influences. But the bottom line is we assume, there's all kinds of reasons to encourage people to have a healthy gut, given what we now understand about the broad reach of the effect of our microbiome. So a high fiber diet, including fermented foods, plant proteins and such would be recommended regardless if there's a unique contribution. This is obviously really important. Anybody who's worked with this population knows that emotional health issues are really common. Numerous studies suggest a connection with depression, anxiety, body image issues, of course. How could they not feel like they're wearing their disability front and center when they interact with any other human being? And this can be particularly stressful when they're in kind of a clinical situation and they're trying to help people understand what they're dealing with. But because of all of this, a lot of this negative stigma and a lot of uncontrolled insulin resistance can feel like I'm craving carbohydrates all the time. It's no wonder that eating disorders are more common, particularly compulsive overeating and bulimia. So whether these emotional challenges are related to hormones, glucose fluctuations, loss of feminine identity, I mean, come on, what could be worse than be dealing with some of the facial hair issues some of these women have? Infertility stress goes without saying, weight issues, fear of chronic disease. So, all roads to this point point to, what is generally good for overall health is good for PCOS, which is a plant-based diet and physical activity. Plant-based diet doesn't mean you have to be a vegetarian. It means that the aim is for 2/3 to 3/4 of food choices to come from plants. So we're all aware of the role that the uniquely challenging role of infertility in women with PCOS. And, I think I'm just going to skip through this rest of this slide because everybody understands the physiology here. But what I actually do with these patients, so I refuse to believe that people can't understand endocrinology if you just take some time to explain it to them. So I actually use this slide with my patients, and I talk about the hypothalamic pituitary ovarian axis. I kind of try to draw them into the conversation by thinking of their endocrine systems, sort of like planets in a solar system that sort of evolve, orbit around each other and assist each other, and sometimes they can collide. So if we talk through, what does it take to produce a potentially fertile cycle every month, and how important continuous hormonal communication without disruption is to that. If I then engage them in a conversation of like, if over here you have your glucose metabolism and it's doing something different to try to regulate your blood sugar, well, the fallout of that excess insulin that your body may be producing to regulate your blood sugar, given how delicate the hormonal balance is, could be eking out into this area of your reproductive health. We also talk about hyperinsulinemia is also pro-inflammatory and is not good for egg quality as well. So understanding PCOS requires understanding the many aspects of insulin resistance and insulin's many functions. So I already talked about most of this stuff. But the last point I wanted to make here, so, you know, again, the growth hormone piece, as somebody who works at Dana-Farber as well, I find very intimidating. But it's also important to understand that anabolic hormones, insulin is an anabolic hormone that affects your brain. It makes people hungry. So when people who are insulin resistant and women with PCOS seem to be even more prone to this, our brain, which gram for gram, your central nervous system burns about twice the fuel of any other tissue in your body, which makes sense because your central nervous system is the primary, most important organ system. Our brain likes to see fuel and it likes carbohydrates. So we spend a lot of time demystifying that carbohydrates are not the devil. There's a big difference between Skittles and quinoa, you know, or fruit. So we spend a lot of time talking about the quality and the quantity of carbohydrates. But our brain likes a continuous source of fuel. So I spend a lot of time talking about spreading, you know, foods out, particularly carbohydrates that hopefully are minimally processed as often as possible. Though I continuously repeat my belief that the 80-20 rule applies and is adequate. I don't care what people do 20% of the time. I'm interested in 100%. It's important for people to hear, these women to hear this message, because they go online and they read all kinds of craziness that suggests they have to follow all these really, you know, kind of over-restrictive diets without any evidence behind them. So they're very vulnerable to misinformation. But because of, you know, a lot of what they're hearing is to severely restrict their carbohydrate intake, many of them are constantly craving carbohydrates. So our brain likes our blood sugar to basically kind of roll steadily over the day. And if women are insulin resistant, they may have more of a tendency for their blood sugars to surge and drop, which can have an effect on their energy levels throughout the day, make them feel hungry frequently and not feel satiated long after eating. Binge eating, again, is not uncommon. Many describe being addicted to sweets, constantly craving them. Irritability, if they go too long without eating, we all do that. You know, that's hangriness. It's your central nervous system saying, I'm not happy, you're not fueling me adequately. In my experience, these women experience that, many of them very severely. And they also tend to be pre-intolerant of very low calorie, particularly very low carb diets. So what are the common issues in women with PCOS? Highly subject to misinformation on over-restrictive diets. Gluten-free, dairy-free, keto. You know, I'll talk more about what the actual evidence is on these in a minute. But when a lot of women say they're following keto, they're not really following a ketogenic diet as would be prescribed with for a child with severe seizures. Many of them are actually on an Atkins kind of a diet. But they're always some sort of a very low carbohydrate diet. So I spend a lot of time saying, yes, you know, too much processed carbohydrate, which is very easy to do in this world that we all live in, isn't great for insulin resistance. That doesn't mean the answer is to get rid of all the carbs. There's a huge quality and quantity issue. I talk about this a lot in my clinical interactions as well as in my book to make clear there's a middle ground here where the quality of the carbohydrate choices, if they're whole foods based most of the time and spread out over the day, to kind of try to replicate this rolling hills sensation of blood sugars to help control cravings. Many of these women often respond or report feeling much better eating like that. They often have a lot of history of what we would call yo-yo dieting or weight cycling. And again, as long as they're in this sort of anabolic state, it can be harder for them to lose weight. So, you know, again, we're dressing this up in a different outfit. Let's talk about managing insulin resistance, which may make it harder to lose weight. And the same strategies will likely contribute to them actually losing some weight. Again, trying to steer around some of the pitfalls. Disordered eating, I already mentioned. 1 study from Australia of over 8,000 women found disordered eating in 11% of women with PCOS, as opposed to 7.6% in age-matched controls. As I just mentioned, carb cravings, insulin, binge eating, and stress eating, of course. You know, everybody knows what stress eating is right now with this pandemic. These women may be more prone to stress eating. And unfortunately, they often come to see somebody with like me, with an expectation that they're going to leave their first appointment with a diet. Like, here's a piece of paper, follow it. And so it's definitely much more of a process because I'm interested in helping them develop sustainable changes they can live with forever. Because yes, I want, you know, many of them come to me because they're referred by Boston IVF and they're trying to conceive, but I really don't want them to develop diabetes either. And, you know, estimates are that 50% of women with PCOS will be diabetic or pre-diabetic by the age of 40. So in terms of what does the research suggest in terms of giving us hints of types of dietary influences? So dietary glycemic index tends to be higher in women with classic PCOS phenotype and is associated with a less favorable anthropometric and metabolic profiles. Low GI diets, a little higher in protein associated with improved insulin sensitivity and less inflammation based on the CRP. I want to say something about glycemic index. It is not a purely interpreted, it shouldn't be interpreted purely because there's a lot of idiosyncrasies with the GI, but the gist of it is the less processed a carbohydrate is prior to consuming it, the less work your body is going to have to do on the inside to finish it off, because processing is sort of like pre-digesting a carbohydrate. They're likely to raise your blood sugar faster. And the presence of fiber obviously will slow that down, as well as pairing carbohydrates with proteins and things that I'll touch more about in a minute. So this was another study, greater weight loss may be achieved with higher protein, lower GI, but symptoms of PCOS improve with weight loss regardless of how it's achieved. So we clearly don't have a one size fits all, which is true of all weight loss endeavors. So what's the best diet therapy? What I do with these women is I generally focus on what helps manage insulin resistance and how that may trickle down to managing their hormones, maybe make them more able to lose weight, enhance their fertility, reduce the risk of diabetes. I regularly get in my office women with PCOS who are way over restricting their diet. In fact, I have one patient who was eating 1,200 calories a day, and she knew she was doing it because she was logging it with a platform, and she was doing 2-a-days at the gym and was not losing any weight. And it wasn't until I actually got her to eat close to 1,600 calories that she was able to actually start losing weight. So, you know, weight control is clearly not just about math. There's a lot of influence related to time of day and eating, quality of the diet, genetics, body composition, and so forth. So there is no consensus at this time, though generally speaking, higher protein, lower carbohydrate diets have traditionally been thought to help women manage weight and improve their metabolic dysfunction. So again, that's not a low carb diet. This is too much carbohydrate, particularly of the junky type. Low carb is unsustainable. I'm not interested in helping people take on one more unrealistic diet that they won't be able to stick on. Temporary change leads to temporary weight loss. And this is 100% how I feel about keto, which is being heavily advocated for women with PCOS. I've been doing this for 34 years. I don't see keto as any more sustainable long-term than any other over-restrictive diet. And in fact, a lot of the evidence of the research I've seen on weight loss and ketogenic diets is that initially people may lose some weight, but that about a year, the weight loss from following a ketogenic diet versus another mode of calorie modification, the curves tend to meet up. So I don't know anybody that can eat like that forever. Might be the rare bird, but it's certainly not something that I consider clinically widely applicable. But the reality is protein is also more satiating than carbohydrate. It also helps to preserve lean muscle mass during weight loss, so that we understand that about 25% of the weight that people lose during a weight loss process is about 25% of it is lean muscle. We don't want you to lose lean mass. We want you to maintain it because that may help counter some of this yo-yo dieting that could occur, that every time somebody radically loses weight and dings. Their lean mass may come out of a weight loss diet with a slower kind of metabolic rate. So trying to find this kind of middle ground where we're spreading the carbohydrates out, but also providing protein regularly over the day in the setting of doing some strength training is the best that we can do to preserve some lean mass during a weight loss endeavor. Protein requires less insulin than carbohydrates. It is involved to some degree, but it does complicate digestion. Meaning if you pair carbohydrates with protein, if protein, kind of delays gastric emptying some, it may help to mute that postprandial glucose surge and make it and extend it so that people are more satiated by what they're eating for longer. But there is not research to support really high protein, really low carb diets, which are often high in animal fat and may promote binge eating due to hypoglycemia. Okay, so what about on the fertility world? We know that adipose tissue, we used to just think that it was a kind of a calorie reserve left over in case we encounter another drought or famine. So I think it's helpful for us to remember that human evolution is super slow, and on many levels our body still thinks we're Stone Age people. So storing fat comes very naturally to the human body, and body fat is not inert, it is metabolically active, chugs out hormones that aggravate insulin resistance. But obesity is associated with reduced fertility with or without PCOS. And if we consider that 2/3 of women aged 20 and older in the US have a BMI above 25 and 36% are obese, we have a significant problem relating to having obesity and fertility challenges. So again, even modest weight loss improves fertility in PCOS by improving insulin sensitivity, lowering circulating levels of insulin that may disrupt hormones, and likely doing other things that we're not fully appreciating yet. More even obese ovulatory women, so again, this isn't even necessarily with PCOS, have higher rates of infertility, likely related to egg quality because of the pro-inflammatory nature of insulin resistance. And I think it's important to point out that obesity can negatively affect the genetic material and reproductive cells in both men and women. But, we have to acknowledge that weight loss is hard. We're all humans. We've all probably, many people have struggled with this one way or the other. It is not easy to lose weight, and it can be even more difficult for these women. So I'm very, very focused, even when I was I'm all virtual now, but when I was in the Domar Center, I had a scale in the corner of my office that somebody stood on about 10 times a year. I didn't want that to be the association of the relationship I had with people as the person who was always going to be weighing them. I'm so vested in trying to get them to notice how their body feels differently when they cut down their refined carbohydrates, when they eat regularly, when they eat a little more protein, when they increase their vegetable and fruit intake. Basically, it's an anti-inflammatory plant-based diet that helps people feel also physically and emotionally better as well. But, I've seen that time and again, overemphasizing weight loss can pummel self-esteem and impair ability to appreciate other benefits that may in the long run make weight loss possible. So I understand this is not an easy nut to crack, but I think, there's more than one way to tackle this problem. And if we focus on, let's get you eating healthier, let's talk about an anti-inflammatory diet, let's talk about, the emotional benefits of regular physical activity, and try to just, again, steer around some of the pitfalls to the best of our ability to get these women feeling empowered enough to feel like they can positively influence their health. So obviously, diet and lifestyle factors are synergistic. And so we need to, kind of touch on all of these over time. Sleep is a huge one. Technology, we know, keeps all of us awake way too late. So these are the things that will get touched on over time. So when I'm doing a nutrition intervention with a patient, the patient guides the process. But generally what we do is, I always tell people, like, I don't know how much you do or don't know about PCOS. So it's important for me to figure out where the holes are in your understanding. And so I walk them through, the, hormone balance for assisted reproduction or for fertility, and then insulin resistance and how those things can interact with each other. And I actually see a lot of light bulbs go off And a lot of what we talk about explains a lot of what these women feel their relationship is with food and energy and body image and, a lot of their weight loss baggage. So weight loss via a variety of means may improve health outcomes, but sufficient evidence does exist for moderate carbohydrate plant-based eating, encouraging fiber, whole foods-based, low glycemic load, and eating a little bit more protein and fat, but there is no evidence for extremes. Carbohydrate distribution over the day is more important than total carbs, and pairing carbs with protein, as I mentioned, can enhance satiety. I think there's a big role for healthy fats. I talk a lot about eating nuts and nut butters and all those things that those of us, I became a dietitian in the late 80s when fat was like the enemy. We now understand that fat is satiating. It's the quality of the fat that matters. There's a big difference between eating nuts for a snack and eating out all the time and eating a lot of fat that you don't even realize you're consuming. I almost never talk about physical activity as a calorie burner. We talk about it as critical to enhancing insulin sensitivity. And I'll talk more about that in a minute, but the recommendations would be, as it would be for anybody, some sort of cardio, 30 minutes most days of the week, and 2 or 3 episodes of some sort of strength training. But again, people need to start where they feel capable, and if that is 10 minutes, 4 days a week of walking, and then you just build on that and feel good about it, then that's the road that we're going to take. So I spent a lot of time actually running through glucose metabolism, and this makes so much sense to people. When you talk about, yes, if you over restrict because you're trying so hard to diet until it blows up at about 4 or 5 in the afternoon because your central nervous system is totally underfueled, that kind of conversation helps them to appreciate that, oh, I'm not just addicted to carbs, and I'm not just a weak loser who lacks willpower, but all the stuff that I'm reading about that I should do to manage, my weight or my PCOS is actually setting me up to crave carbohydrates because that's what the brain, the central nervous system, likes for fuel. I would encourage people to steer clear of saturated fats and trans fats, and that includes at this point a lot of coconut oil. I always tell people, if you like coconut oil and it has a high heat point, it's good for cooking with high temperatures, but overall, I know of no advantage in the way from the coconut oil that most people are buying in, Trader Joe's, as opposed to what might be customized for a research study for MCT oil. It doesn't convince me that monounsaturated fats aren't better, and omega-3s from seafood and supplementation if necessary. Portion control only comes for any of us if we try to proactively manage our hunger. If we go too long without eating and our blood sugar drops, our primitive cave instinct is going to be to overeat at the next meal, and this is no different for women with PCOS. So a dietary pattern, it's no different really from this balanced plate that now is the graphic that the USDA uses to depict healthy eating. This is the Harvard Healthy Eating Plate. These are basically a Mediterranean diet on a plate. So we talk a lot about, antioxidants, plants containing over 100,000 different compounds that act as natural antioxidants, anti-inflammatories, detoxifiers, fiber, how good it is for you. And then just, spend a lot of time talking about trust the infographics. So infographics are there to translate a lot of complicated science in a way that the average person gets confused by. So if they just I propose 2 different kind of options of balanced plates depending upon how the day is going, and say trust that the infographic is depicting enough protein, a moderate amount of carbohydrate, and a lot more fruits and vegetables. I already mentioned this, but carbohydrates that have retained their fiber and consumed with fat and protein tend to have more staying power after eating. We talk a lot about carbohydrates, refined, those that are refined versus those that are not. I make it clear to people there are no foods don't affect your health turn your health on and off like a switch unless you've got an anaphylactic allergy. So there's plenty of room in a healthy eating plan for someone to have smaller amounts of sweets and things that I call food for fun. But we do talk a lot about experimenting with whole grains, loading up on non-starchy vegetables, and limiting added sugars, because most of these women will notice the more sugar they eat, the more they crave it, and it's likely some effect of blood sugar surging. Where your blood sugar goes, your insulin goes, and then your blood sugar drops, and then your brain gets irritated and it wants more sugar. I only do carbohydrate counting, and it's just based on the American Diabetes Association way of doing it, to help people interpret food labels and to interpret their food logs that they get from the multitude of apps that are available. Generally speaking, per meal, if you think of like 45 grams of carbohydrate as being sort of the anchor, it sort of fluxes 30 to 60 grams per meal. So sometimes I get asked, how many carbs should I eat in a day? It's not in a day, it's in a per meal eating episode, because we're interested in these postprandial glucose surges. And evidence suggests that women with PCOS may have a particular problem in the postprandial phase. So they may have actually good fasting glucose levels, but struggle more after eating, which is probably why that oral glucose tolerance test unearths more prediabetes. Protein, obviously we're going to superimpose lean protein, aim for 20 grams per meal when at all possible, including plant sources, including soy foods. And plant protein may be potentially beneficial for fertility as well. Dietary supplements, I don't want them to be vitamin D deficient if they're on metformin, in particularly if they're on metformin and omeprazole. There's many women that are on both. They need to be monitored for B12 deficiency and supplemented. I encourage them to eat fish. They can take fish oil supplements if they want to, including DHA if they're trying to conceive or pregnant. But I encourage them to avoid high-dose single herbs and supplements. If they're cycling, they need to act like they would if they were pregnant. Inositol is a natural insulin sensitizer. The product our go-to is Ovasitol by Theralogics. They have a single serving is 2 grams of mayo and 2 grams of mayo and 50 milligrams of D-inositol twice a day actually stacks up fairly decently towards metformin in some studies. NAC is another option. Berberine, I don't use a lot of NAC and berberine in my practice because my women are mostly cycling and nobody studies pregnant women. We're not going to have a lot of evidence on these. So in terms of their commonly encountered concerns, soy is the devil. It's got estrogens in it. We know from the breast cancer world that phytoestrogens, if anything, may actually be protective against ER-positive breast cancer recurrence, and at a minimum, it doesn't look harmful. Genistein, which is an isoflavone, consumption may prevent cardiovascular and metabolic disorders in PCOS patients by improving the reproductive hormones and the lipid profiles. Dairy, again, it gets demonized for everything on the internet. There is some research suggesting it may affect cystic acne in some women, so that's irrespective of PCOS. But if that's a part of a woman's experience with PCOS, she may want to kind of ditch dairy for a month or so and see if it affects her skin. But I don't limit it. I'm comfortable with a couple servings a day if people enjoy that. Particularly yogurt, Greek yogurt in particular, is a great snack high in protein. PCOS involves inflammation, so the claim is that gluten, or wheat, or both are pro-inflammatory. This is not an evidence-based recommendation. Avoiding gluten-containing foods often involves cutting a bunch of carbs out of your diet, including the junky ones. So it makes it very difficult to determine whether the positive feeling that someone is experiencing is because they cut out a lot of the junky carbs. I will tell you that a lot of food surveys find that people on gluten-free diets, the diet quality tends to be poorer, probably because of a lot of potato bread and white rice and processed foods. So I can't find anything to suggest that women with PCOS are any more likely to have celiac disease, for example. But it is important to get tested before a woman does a gluten-free diet in case they do have celiac disease. Again, I talk a lot about exercise as managing insulin sensitivity and lipid profiles. Exercise, it gets a little bit iffy about the role of exercise during weight loss, and that's like a whole nother conversation, but it appears to be particularly critical for maintenance of weight loss, mobilizes visceral fat. This right here is, the most important piece of my conversation with women. Insulin's basically only supposed to have to unlock your cells, and then glucose transporter proteins are supposed to jump into action start yanking the glucose out of the blood, and transporter proteins are triggered at the are produced from physical activity. So we talk about physical activity as an insulin lowering strategy as opposed to a calorie burner, to change the conversation. And it's the recommendations are 150 minutes of moderate activity a week. If someone's trying to lose weight, they may want to up the bar to 300 minutes, but also include some strength training activity. So how do you know it's working? They may lose some weight. And again, huge hurrahs for any degree of weight loss, particularly if someone does some strength training in the process of trying to improve their health. Weights don't tell us everything we'd like to know about body composition. But again, as little as 5 to 7% weight loss may make a difference. I often see my patients' A1Cs go down. Really important, they report feeling less emotionally labile. They feel more in control of their cravings, lots of expressions of feeling empowered and better about themselves, better about their ability to feel like they can deal with this. But as long as they're just constantly like, I gotta lose weight, I gotta lose weight, I gotta lose weight, and they're confused about how to do that, it can just make it, it can just be like handcuffs, makes it difficult for people to get beyond that. And of course, the goal is more consistent ovulation. So that was a lot. I apologize if I went a little bit long, but Alyssa, I'm guessing that you have any questions?
Yeah, no, that was great, Hillary. We have a few questions. So one was, can you please explain more on PCOS and the microbiome and give some suggestions? And then there was an example, like what is 25 grams of fiber? What does that mean on a plate? Also, what is miso? These will be helpful, practical when counseling patients.
So miso is a soy, it's a fermented soy food. It's a plant, you know, it has protein in it. And so it's a healthy thing for people to consume. So we know that the healthy bacteria, you know, estimates are we carry around 3 or 4 pounds of healthy bacteria in our GI tract, mostly in our colon, that feeds off of fiber. So we now understand that a healthy microbiome helps to quell inflammation, you know, lowers your risk of colon cancer by the healthy bacteria digesting dietary fibers and producing short chain fatty acids, which are primary fuel for the enterocytes that line the GI tract. So again, we don't know a lot specific to PCOS, but I would just say we know that all of us have a lot of work to do to increase our fiber intake. So to give you an idea, 25 grams of fiber, you're not going to see that on one plate. It's something that people have to try to accrue over the day. I can tell you that the average American's dietary fiber intake is 11 to 12 grams. So that balanced plate, if applied at meals and snacks, and also I give them lots of ideas of snacks that include whole fruits, not juice, whole fruits, vegetables, nuts, seeds, beans, whole grains like brown rice, wild rice, quinoa, farro, barley, amaranth, you know, experimenting with some of these ancient grain kinds of things. But in order to accrue 25 grams of fiber by the end of the day, you need to be looking for ways to put plants into your breakfast, into your lunch, into your dinner, and into your snacks. So, you know, it would be like the highest fiber foods are like bran kind of grain things, like bran flake type things, but also beans are loaded with fiber, a third of the carbohydrate in beans, and that would include hummus is dietary fiber. Nuts are an excellent source of fiber. And then again, all fruits, vegetables, and whole grains. So the idea is people need enough eating episodes, you know, laid out over the day to try to get those fiber containing foods in there in order to reach that 25 gram goal.
Great, thank you. All right, we have another question. When a patient is recently diagnosed with PCOS, can you give recommendations of some tools for counseling and maybe some, I know you have, you know, obviously your book, but is there anything else that you use to help with counseling patients to help them understand PCOS?
Yeah, I mean, now since I had to go remote like everybody else, I had to convert all my education materials into a PowerPoint presentation. So I literally, with every woman with PCOS, I always ask permission for everything I do, but I, you know, say, do you mind if we talk about what does it mean to manage insulin resistance? And I literally show them that graph that I showed you, where we talk about, you know, this is a blood vessel, this is glucose in your blood. You have to have some glucose in your blood at all times, or we'd be dead. You know, all the cells in our body use it as fuel, but our brain really, really needs it. And I tell them literally, like, if you had a gram of brain matter here and a gram of muscle tissue here, your brain matter is burning twice the fuel, and that's you know, not surprising because we need our central nervous system to survive. Hold on one second, my computer seems to not be plugged in. Sorry about that, the plug came out of the outlet. So I do a lot of trying to teach scientific concepts in simple layperson's terms so that they understand that it's not that all carbohydrates are bad, it's the quality. Where is it coming from? Is it a whole foods-based carbohydrate, a fruit or a vegetable or a whole grain or beans, or is it processed carbohydrates? The whole grain ones contain fiber. Fiber slows down digestion because humans can't digest fiber. So it's anything that we can do to complicate how fast your blood sugars rise after meal will contribute to lowering those insulin levels. And I continually draw their attention back to, we're trying to get this insulin thing under control. And in order to do that, I really want to try to help you proactively eat instead of reactively overeating when you're starving. So I have in my presentation, I have a hunger chart of 0 to 10, where 0 to 2 is not hungry, like how somebody feels after eat a satisfying meal, not like a lean cuisine, but something that's actually satisfying. So I'll try to get them to give me an example of something that they eat as a meal that makes them feel full for a while and help them understand why that might be. On the other end of the spectrum, you have hunger that's an 8 or a 10. That's not a psychological place. That's a physiologic condition. When we are that hungry, our blood sugars are lower, our hunger hormones are high, our primitive cave girl is going to want us to go, grab whatever's fastest, quickest, cheapest. So I talk a lot about reactive overeating because we're waiting too long to eat, or we're being such good dieters until 4 or 5 o'clock when your brain is finally done with it. And thereby encouraging them to try to proactively eat when they're like a 5 or a 6 on that hunger scale. And to try to get them to think consistently about pairing carbs with protein. So if you have a snack that's like Cheez-Its, you're going to be hungry again in an hour. But if you find some whole grain crackers, so after the word ingredients on a box of crackers, cereal, bread, you want to see the word whole. So if you have a whole grain and then you pair it with a protein, so not Cheez-Its maybe, but Wheat Thins or Triscuits with cheese or hummus. So I try to kind of tease through, like, what is a whole grain that's acceptable to you? What is a protein source that's acceptable to you? And get them to say, to me, they'll often say, oh, I notice when I eat like eggs and whole grain toast and a banana for breakfast, that holds me a lot longer than if I grab a bagel. So we talk about, prolonged blood sugar curves as opposed to spikes and drops. So I try to draw their reported experiences into why that might be physiologically, because otherwise everything feels like a personal failure. Like, I eat too much because I lack willpower. Well, we don't have a lot of willpower. It never favored human survival. What favored human survival was opportunistic eating. Eat what you see. That's what we're supposed to be doing. Unfortunately, we now need to be mindful eaters. Again, that's why I do have the ability to engage them in a nutrition logging platform called Good Measures that I'm allowed to use with my clients, that I can actually see what they're logging. So I don't go in and creep on them, but when they meet up with me again, I can actually pull up their logs on the computer and we can look through their data. I would not give that to somebody who I thought had an eating disorder, and it's totally doable even with a written log. But just, that's why journaling helps. If you're journaling, it puts the issue here. Whereas our normal relationship with mindful eating is pretty not front and center.
Great, thank you. And I believe this is our last one.